Good afternoon, everybody. Thanks again for the keen invitation to this great meeting. I was asked to give a talk about the complex EVAR, and the question is to see what to do and what are Bailout strategies. So I will share with you some of my experience and how to solving problems with these procedures. Well, what is a Bailout? A Bailout is supposed when a business or individual government provides money and all resources for filing a company. I prefer this medical definition. Bailout procedure are procedure used to save the limb for the patients. So I will not take for first choice procedures in EVAR. And rescue maneuvers and bailout strategies require training previously because it's not easy to do in a complex situation in emergency, something you have never done. So don't try new things. So the first, I will show you with you a case of a chimneys and periscopes bailout technique during physician-modified endograph case. It is an 80-year-old man with active neoplasia treated by oncology with an expectancy of life superior to 2 years, so we decided to do the procedure because also he presents a massive type 2 endoleak and type 1 with a 9 centimeters AAA treated 7 years ago in another institution with an endurance device. Here we can see the video. Can you play the video, please? No, go back. Okay, can you play it or not? Okay. So it was a large 9 centimeters aneurysm with endoleak. This was the planning of the case. The planning was a physician-modified endograph, a Valiant device with 4 fenestrations and using 4 covered stents. That was initially the plan. And this is how we do this kind of procedures. So sometimes they are not usually elective procedures. In some case elective because we don't have available the technology, but usually we just open a little bit the device, we make the marks, and we crimp the device with a crimper that they use for TAVI. So you have to be very careful. For 1-2 fenestration it's quite easy, but when you do 4 fenestration, you go so far, it's more complicated. And this is what's happens sometimes with when we do this kind of procedures. Here you can see the problem, and probably the oversizing was too much. And 2 of the fenestration were okay, the selectron and the superior mesenteric, but the renal fenestration, look how they are looking. And it's something very complicated to solve during the procedure. So something I have learned also from my senior experience in endovascular procedure, like Ryan O'Neill or Jorge Fernandez, is that at least you need to leave the room with a renal patent and a visceral vessel patent, especially the SMA. So in this case, I could do the SMA, but I could not do the renal through the graft. So there is always a plan B on the mind. And my plan B was doing periscope in this case. So for the left renal, I use a parallel going outside from the sac and from the stake, parallel to the leg. We could reject the sac, and from the sac, the left renal, and then I put 5 covered stents from the renal to the left iliac. You know, like in the old times, we did sometimes in every procedure doing a bypass from the iliacs to the renals. And thank you. And for the right renal, I do quite similar. I do a sandwich between the previous graft and the new one with extending to the sacs. So this is the final angio, and we can see in the video, if it works, that there was no endoleak and both renal artery were patent and the MSA was patent. And this is the patient with remission, discharges at day 3. He keeps on chemotherapy, and 2 years later, he's doing right, and he's back to his country.
Buenos días, señor. ¿Qué tal? ¿Cómo se encuentra?
Okay, so lesson learned from this case is that probably this is an example of what sometimes happen with EVAR. There's a lack of appropriate follow-up during 5 years. We know that physician-modified endograph helps to solve emergency or complex anatomy, but we need to think when we are doing 3 or 4 homemade fenestration is quite complicated, especially when they are not opening the sac in a narrow artery lumen, like Nilo commented previously with the outer branches. Here, it's better to use better tools to plan and sizing than just a paper and a hand. So 3D print is coming, and new measure tools to measure this device are coming also. And we need to understand that stent graft, when we do these maneuvers, opening and crimping again, they can twist easily. And if they are twisted, it is very difficult to solve. And in this case, periscope saved the case because this plan B was in mind. Here is other example of Bailout technique chimneys in an emergency. It was a 76 years old man with acute abdominal and back pain and a 7.2 centimeter thoracoabdominal type 4 aneurysms. He was stable, but hemoglobin was moving down, so we decided to do it emergently. If we can run the video, please. Okay. You see the large aneurysms, symptomatic, and with signs of immediate rupture. The wall of the aneurysm is not well defined, and suprarenal. Okay, so in this case, I decided to do. I need to go fast. Take more time to me to do 4 L3 physician-made penetration. So I decided to do 2 chimneys from above and one periscope from below. Why? Because it's not recommended do 3 chimneys from the same side. So it was not complicated to catheterize. So I could do the case in less than 2 hours. And it was a damage control procedure. So what was bleeding was the thoracoabdominal aorta. The infrarenal aorta was okay. And here we can see how it works well for the SMA and the right renal from above. Due to the anatomy was easy, this anatomy was quite easy from down, so I did from down. And here I use a Viavan because something there's a lot of curves or a long diameter. I prefer to use Viavan than other kind of covered stents. And this is the final control of the procedure. You can see here all vessels were patent, and we did the control. 2 days later, we can see how the vessels are patent. So in this case, 2 solutions were 2 chimneys for SMA and right renal and 1 periscope for down, and it was a damage control procedure. So the patient was scheduled for a second time procedure to treat the abdominal aortic aneurysm 3-4 weeks later, but the problem is that 18 days after procedure, he has a massive gastric bleeding. We did a new scan, everything was patent, but the patient has exodus. And the third case is how to solve with this technique, Bailout chimneys, problems during EVAR. It was a 73 years old man with obesity, 6 centimeter juxtarenal AAA, asymptomatic and planar for inner branches, EVAR, because the size of the aorta was not very big. This is the CT previous to the procedure. It was a scheduled patient with a 4 inner branch. Okay, this was the planning of the procedure, making it with detail. Everything was well scheduled, and we started the procedure. Everything seems to be okay, and I catheterized, no problem, the SMA, the upper vessel, but I start to have problems with one of the renals, and it was my personal fault that this maneuver can happen. I decided to try to balloon in the stent graft to fix it prior to catheterize the vessel, and because the neck was not very good, and what happens after this ballooning, all the stent graft moves 2 centimeters down, 1 centimeter. If you do this with inner branch, you are in troubles because it's very difficult then to go to the vessel up. So internal branch, when they move down from the target vessel, is very complicated to fight with this angulation. And you can see here, like it was almost impossible to reach the right renal. So I decided to do also a periscope to solve the situation. And you can see here in the control how we can save the cases, because if not, it was not possible to save this renal. So here you can see it is a very, very long conduit, endoconduit, but it seems to work, and this is 1 year later, and the CT scan are okay. So just to finish, the take-home message are that now we have new device, more standardized, and probably these cases could be approached with other devices nowadays. There are some of them from 3 years ago. But we also have to bear in mind the techniques from other coders, like the coder from Brazil, who developed all the techniques from parallel graphs, because it helps to solve problems to save case. Always have a plan B on mind for complex EVAR. Even if your planning seems to be perfect, you need to have a plan B. Because your plan B is what saves life in many times, and you have to have in your stock a lot of covered stent and different devices. And stupid ideas or failures like I have here, they need to be shared also with the community, because we all need to improve about this complex thoracic aortic aneurysm. And thanks very much. We invite you all to sit next year with Professor Brown, Neil, and Mark are doing a great job. And I work in Marbella, also in my hospital. You are also invited to come when you want.